Hi guys, this is John Adamson, the Rehab and Documentation Guru. So, a little bit ago, I got done doing an evaluation of a patient, 59-year-old guy, status post CABG times 4. He had a lot of medical history, including diabetes with associated complications. He also had a history of chronic pain, like 30 years of pain. And that pain was caused by fractures to his spine. So I had read the nurse's note from doing the case opening, and the nurse noted that the patient's gait was stable and that he was already walking a couple miles per day. Now, the patient was under an insurance type that did not require homebound status for home health, otherwise he definitely wouldn't qualify. So it's not an insurance issue. If he needs therapy, he needs therapy. So I went in and I took a look at him, and my EMR for PT has 2 standardized tests built in, which I generally go ahead and use. Sometimes I'll use some other stuff that's not built into the system. But for him, I went ahead and did that, and that was the 30-second chair rise and the Tenetti. I like both tests, and they have good psychometric parameters behind them. So I did the 30-second chair rise, and the guy got 9 repetitions, which is below age normative. If you compare him to a 60-year-old male, which is as close as I'm going to get with him, he should be able to do at least 12 repetitions. So the standard deviation, or the minimal detectable change for that test, is 2 repetitions. So he's more than 1 standard deviation below normative. So I know he's a little bit weak. But he's walking 2+ miles. He also has peripheral neuropathy. And when he did the test, it was pretty clear it was not too hard for him. And he did not have to use his arms. There was no modification to the test. And he had no shortness of breath when he did it. All his cardiac signs were normal. So he did fine, despite having a recent. So looking at that strength just by itself, number one, I have to keep in mind that Medicare does not pay for therapy services for general strengthening and conditioning in the absence of a complicated medical condition. And looking at him, he's post-CABG. That's the reason I'm in there. He's not complicated because I'm not seeing any cardiopulmonary impact while he's doing this activity. So I have to ask myself, can I do strengthening on this guy? Because he could move towards age normative. It would be a minimal detectable change that would demonstrate the necessity, or the efficacy, I should say, of therapy. But I really couldn't justify it because he's already walking a lot, he's returning to normal activity, and it's reasonable to expect that with return to normal activity, he's just going to gain his strength back. So I really wasn't worried about it. Now on the Tenetti, he's a 59-year-old male. He scored a 28 out of 28 on the Tenetti, despite his peripheral neuropathy. So number one, what does that tell you? He is balancing very well despite some clear loss of peripheral sensation. He's not operating with a full set of senses that will help with his balance. But he's at a 28 out of 28. Now the problem with the Tenetti is that it has a ceiling effect. A ceiling effect is when a person can score the highest possible score, but they're necessarily at the highest level of performance that they could be. Somebody could be 28 out of 28 on the Tenetti and still have opportunity in gait and balance, the 2 areas that it measures. But he's perfectly fine. He has a low fall risk, and there wasn't really any need to go above a 28 out of 28. So the other thing I look at is he's walking 2 miles already per day. And he's feeling good. So the question is, does he really need a home therapist to bill his insurance, which doesn't care about homebound status, but I'm still an outpatient clinic. So I have to look at it from an ethical reimbursement perspective. Am I really needed in the home? And it's clear that I'm not. And so based on all those things, the fact that he did so well on his performance testing, it's reasonable to expect he will continue to improve. He's got a low fall risk, and he should just get back to his normal activity. I couldn't justify care. And when I got done with the assessment, the patient looked at me and was thankful, and he said, I was a little bit concerned that you would suggest therapy that wasn't necessary, because I think I'm doing fine. And that brings up the ethical concern that our patients these days are much more savvy to the value of their healthcare dollar. And so we've got to be mindful of that when we're prescribing. You know, there's some patients and some caregivers that push for more therapy than is necessary, but there's a lot of savvy ones that don't want to overtax the system that's already overtaxed. They don't want to get care that they don't need. And so we really need to be clear about the reasoning, the rationale for all the care that we offer to the patient, and be able to reason through what would be necessary for the patient. And in this case, it was pretty clear I was not needed. Anyway, this has been John Adamson, the Rehab and Documentation Guru, talking through a little case scenario about reasonable and necessary care, and hoping that you will not only like and subscribe, but send me some possible scenarios or documentation scenarios you'd like me to discuss. You can send that to Adamson Enterprises, the number 1 at gmail.com, Adamson Enterprises 1 at gmail.com, or leave a comment below, and I will see those on my alerts through my YouTube channel, and we'll be happy to answer those questions or comments or concerns. Anyway, take care, God bless, and have a great day. Bye.